Our topic today is about the shoulder joint. We will discuss in this lecture the type of the shoulder joint, the articular surfaces that forms the shoulder joint. Then we will describe the attachment of the fibrous capsule and the synovial membrane. We will see what is meant by bursa and what are the different bursa present here. Then we will explain the different accessory ligaments. We will see whether the joint is stable joint or not, and what are the causes of stability of this joint. Then we will enumerate the nerve supply of the joint. Then we discuss the different movements, and finally we will give a clinical note. The shoulder joint, as you see, is formed of the head of the humerus and the glenoid cavity. The head of the humerus is rounded in shape, and the glenoid cavity of the scapula is like a socket. Therefore, this shoulder joint, is a ball and socket joint. It is also one of the synovial joints. It has all the characteristics of the synovial joint. It has a fibrous capsule, a synovial membrane, a joint cavity, fluid inside. So it has all the characteristics of the synovial joint. Therefore, the shoulder joint is a ball and socket synovial joint. If you try to move your arm around the shoulder joint, you can move your arm forward, backwards, put it away from the body, upwards. So it has a very wide range of movement, and it can move around multiple axes. So this joint is multi-axial joint, and it is the most mobile joint in the body. It has a very wide range of movement. In this slide, you can see that the shoulder joint is closed by a fibrous capsule. It's like an envelope that closes the joint. And this fibrous capsule inferiorly, as marked by the red arrow, is lax. This laxity in the fibrous capsule causes the wide range of mobility of the shoulder joint. Also, if we look at this, the second picture, you can see that the head of the humerus is large and convex. And this large convex head articulates with a shallow and concave glenoid cavity. So also this large convex head articulating with the shallow part gives a wide range of movement. But this has a disadvantage, that this large head might dislocate or might get out of the glenoid cavity because it is large and the glenoid cavity is shallow. So that to avoid the head being dislocated from the glenoid cavity, there is a rim of fibrocartilage that is attached to the margins of the glenoid cavity, so as to make it more deep. This rim of fibrocartilage is called the labrum glenoidale. Therefore, this labrum glenoidale causes more stability to the shoulder joint and makes the glenoid cavity more deep. This is the fibrous capsule of the shoulder joint. It is attached laterally to the humerus, and it is attached medially to the glenoid cavity of the scapula. Where exactly is the lateral attachment to the humerus? The second picture shows the head of the humerus. It is followed by a constriction called the anatomical neck. The humerus has another neck called the surgical neck of the humerus. So the fibrous capsule is attached where? It is attached to the anatomical neck of the humerus. We will see a red line will be drawn to indicate the attachment of the shoulder joint to the anatomical neck. It is attached superiorly, anteriorly, but notice here when it comes to the medial aspect, it descends down to the surgical neck. It does not continue medially along the anatomical neck, but it descends inferiorly about half an inch to reach the surgical neck. The third picture shows the attachment posteriorly to the anatomical neck, okay, posteriorly. Then also when it comes medially, it will descend about half an inch inferiorly to reach the surgical neck of the humerus. So you can see the lateral attachment to the anatomical neck all through, superiorly, anteriorly, posteriorly, but medially it descends half an inch to the surgical neck. So that the medial aspect of the surgical neck of the humerus will be inside the capsule. Okay, so it is intracapsular. This part of the neck, it is inside the capsule of the shoulder joint. What about the medial attachment of the shoulder of the fibrous capsule? It is attached to the glenoid cavity. Where exactly? To the margins of the glenoid cavity. Here anteriorly, it is attached to the margin of the glenoid cavity. The third picture shows the attachment along the margins of the glenoid cavity, also posteriorly. But we said that the margins of the glenoid cavity is attached also to the labrum glenoidal. The labrum glenoidal is attached to the margins. So where is the capsule attached? It is attached outside the labrum glenoidal. Okay, so that the labrum glenoidal is inside the fibrous capsule. Inside means intracapsular. So the labrum glenoidal is intracapsular. Why? Because the attachment of the capsule is outside the margins, and the margins is attached to the labrum glenoidal. Also above the glenoid cavity, there is a bony prominence called the supraglenoid tubercle. Okay? It gives attachment, as we will see in the next slide, to the tendon of the long head of biceps. So there is a tubercle called supraglenoid tubercle, and also from the picture you can see that the red line is drawn outside the supraglenoid tubercle. So the fibrous capsule is attached medially to the margins of the glenoid cavity, outside the labrum glenoidal and above the supraglenoid tubercle. If we open the fibrous capsule and we will look medially to the glenoid cavity, we will see this picture. You can see the glenoid cavity. Then it is surrounded by the labrum, which is attached to its margin. Outside the labrum, there is the capsule of the shoulder joint. Then above the glenoid cavity, we can see the supraglenoid tubercle giving the attachment to the tendon of the biceps muscle. Therefore, there are two intracapsular structures. There is the tendon of the long head of biceps coming from or attached to the supraglenoid tubercle. Okay, this is intracapsular, inside the capsule. And also there is the labrum glenoidal, which is attached to the margins of the glenoid cavity. It is intracapsular. The fibrous capsule of the shoulder joint has some perforations. Perforations means openings. There are some openings. In the previous slide, we said that the tendon of the long head of biceps, it was intracapsular. It was inside the capsule of the shoulder joint. It wants to come outside, to exit. So it exits through a perforation, which is the lateral perforation. So the first perforation, which is found in the capsule of the shoulder joint, is a lateral perforation for the exit of the tendon of the long head of the biceps. There are other perforations. One which is anterior. There is an anterior perforation, and a similar one which is posterior to the shoulder joint, to the fibrous capsule of the shoulder joint, which is the posterior perforation. These two perforations, the anterior and posterior perforation, are related to something called bursa. Okay, we will see what is meant by bursa in the following slide. What is meant by a bursa? A bursa, it is a sac of serous membrane which is present between a tendon and the capsule of the joint. As you see in this picture, you can see a muscle called subscapularis muscle. It is attached anteriorly to the scapula, and you can see that its tendon, the white part of it, its tendon, passes in front of the shoulder joint to be inserted into the humerus. As the tendon of the subscapularis muscle passes in front of the shoulder joint, there is a sac of serous membrane, or a pillow, just like a pillow, which is present between this tendon and the capsule of the shoulder joint, so as to protect this tendon from wear and tear. This bursa is called subscapular bursa. Also posteriorly, there is another muscle called infraspinatus muscle. It is below the spine of the scapula. This muscle, the tendon of this muscle, as it passes posterior to the shoulder joint, there is a bursa, another bursa, between its tendon and the fibrous capsule, the posterior aspect of the fibrous capsule. This bursa is called the infraspinatus bursa. So there is two bursa, one anteriorly between the subscapularis muscle tendon and the fibrous capsule, the subscapular bursa. Another bursa between the tendon of the infraspinatus muscle and the fibrous capsule posteriorly is called the infraspinatus bursa. This is the subscapularis tendon, and this is the rest of the muscle. I will remove the muscle. This is the tendon, and here is the place of the subscapular bursa between the tendon and the fibrous capsule. And this black arrow shows the anterior perforation, which we just said, which is present in the fibrous capsule. This anterior perforation allows the subscapular bursa to communicate with the joint cavity. So the subscapular bursa communicates with the cavity of the shoulder joint. This is the posterior perforation in the fibrous capsule of the shoulder joint. Okay, and as you see, it is related to the infraspinatus bursa, which is present between the tendon of the infraspinatus muscle and the fibrous capsule. So this perforation, the posterior perforation, may allow communication of the infraspinatus bursa with the shoulder joint cavity occasionally. The third type of bursa is the subacromial bursa. Where is this bursa found? Let us see. From the superior aspect of the scapula projects a process called the coracoid process. And there is another process projecting also from the scapula, but projects from the spine of the scapula posteriorly, and it projects laterally. It's called the acromion. Between the acromion and the coracoid process, there is a ligament called the coracohumeral ligament. The coracoid and the coracohumeral ligament and the acromion, the three of these, forms what is called the coracohumeral arch. The bursa is found below this arch, this coracohumeral arch. Between this arch and a tendon of a muscle called the supraspinatus muscle. This is the tendon of the supraspinatus, okay? And the subacromial bursa is found between this tendon and the coracohumeral arch, so as to protect also this tendon. This subacromial bursa does not communicate with the joint cavity. It's not related with the perforations. Okay? It is present, as you see in the picture, okay, beneath the coracohumeral arch, and it extends deep to the deltoid muscle. Next, we come to the synovial membrane. This shoulder joint is a synovial joint. It has a fibrous capsule, and this fibrous capsule is lined by a synovial membrane. So if we remove this white fibrous capsule, which you see in the picture, I will find the synovial membrane lining the inner aspect of the capsule. Okay, what about the articular surface, the head of the humerus and the articular surface of the glenoid cavity. This is the head, the articular surface, and the glenoid cavity. These two parts are not covered by the synovial membrane. So the synovial membrane does not cover the articular surfaces of the head or the synovia of the glenoid cavity. But as you see, this part is the inner or the medial aspect of the surgical neck. This aspect is lined or is covered by the synovial membrane. Okay. To the glenoid cavity is attached the labrum glenoidale, as we said. So the synovial membrane will cover the labrum glenoidale from both sides. Next we see an extension, a tubular extension from the synovial membrane around the tendon of long head of biceps. So from this picture, we concluded that the synovial membrane lines the inner aspect of the fibrous capsule. It lines or covers the labrum glenoidale from both sides. It covers the medial aspect of the surgical neck. We will see more details in the following picture. In the following slide, as you see here, we took a coronal section in photo A. In photo A, this is the fibrous capsule closing the shoulder joint. I take a coronal section, so I can see in picture B the following. I can see the head of the humerus and I can see the glenoid cavity. Where is the capsule? The capsule is the upper part, as you see in the black arrow, okay, and the lower part. This is the capsule closing the joint. The synovial membrane will line the capsule, as you see, it is drawn in the red line. This is the synovial membrane lining the capsule, okay, and it is lining the capsule also, the lower part. These are the synovial membrane lining the capsule. Okay, the lower part, as you see, it covers the medial aspect of the surgical neck. What about the articular surface? These are the articular surface, the green dotted part. They are not covered by the synovial membrane, as you see. These are the articular surface, not covered by the synovial membrane. If I open in picture A the fibrous capsule and I look from the inside towards the glenoid cavity, this is the glenoid cavity, I can see the synovial membrane, the red membrane is attached to the margins of the glenoid cavity, and it sends a tubular sheath around the long head of biceps. From this picture you can see that the tendon of the long head of biceps is outside the synovial membrane, right? Outside the synovial membrane, but it is inside the fibrous capsule. So it is extrasynovial because it is outside the synovial membrane, and it is intracapsular because it is inside the fibrous capsule. Next, we come to the accessory ligaments of the shoulder joint. We have three accessory ligaments. The first ligament supports the joint from the front or anteriorly. It extends from the glenoid cavity to the humerus, so it is called the glenohumeral ligament. So as you see from the picture, it supports the joint anteriorly, extends from the glenoid to the humerus, so glenohumeral ligament. The second ligament is a ligament that keeps the biceps tendon in its place after the biceps tendon exits from the capsule of the shoulder joint. It passes in what is called the bicipital groove, so it is kept in its place by a ligament which is transverse in position called transverse humeral ligament. We will see in the next slide in details where exactly are they attached. The third ligament is a ligament that supports the joint superiorly. It extends from the coracoid process to the humerus, so we call it coracohumeral coracohumeral ligament. So we have three ligaments, one supporting the joint anteriorly from the glenoid to the humerus, glenohumeral. One supports the joint superiorly from the coracoid to the humerus, coracohumeral, and one passing transverse along the tendon of the biceps to keep it in its position. It's called the transverse humeral ligament. Let us see in details. First, the glenohumeral ligament. As you see, this ligament is formed of three parts or three ligaments: superior, middle, and inferior ligament, and we call it gleno from the glenoid cavity, humeral to the humerus. It is attached to the glenoid cavity where? To the medial margin of the glenoid cavity. So it extends from the medial margin of the glenoid cavity to be attached to the lesser tuberosity of the humerus, the front of it, the front of the lesser tuberosity, and it supports the joint from the front or anteriorly. This is the first one. And as you see also, it is attached to the anatomical neck of the lower part of the anatomical neck. The second ligament is the coracohumeral ligament. It extends, as we said, from the coracoid process to the humerus, coracohumeral. It extends from the root of the coracoid process. There is a ligament, as you see the dotted line. This ligament passes superior to the joint to be attached to the front of the greater tuberosity. So it is coracohumeral ligament. The third one is the transverse humeral ligament. It keeps the tendon of the long head of biceps in its position, as you see here. Okay, this is the green line is the tendon of the long head of the biceps. It is placed in the bicipital groove between the greater tuberosity and the lesser tuberosity, so when we want to keep this tendon in its position, there is the transverse humeral ligament to keep it in its position. It extends from the lesser tuberosity to the greater tuberosity, the transverse humeral ligament. We come to the next point. What causes the stability of the shoulder joint? There are many factors that are responsible for the stability of this joint. The most important factor is the muscles that surrounds the shoulder joint. Let us see what are the muscles that surrounds this joint. This is the anterior view. Okay, we can see a muscle called subscapularis muscle is attached to the ventral aspect of the scapula, and this muscle, its tendon, goes to be attached to the humerus. Okay, and as you see, this tendon passes in front of the shoulder joint. This tendon, as it passes in front of the shoulder joint, it fuses with the fibrous capsule. So the tendon of the subscapularis from anteriorly fuses with the underlying fibrous capsule anteriorly. So it supports the fibrous capsule and supports the joint anteriorly. This is the subscapularis, and let us stand for it with the letter S. If we turn the scapula backwards, let us see posterior, the back view. This is the spine of the scapula, as you see. Above the spine, there is a muscle called supraspinatus. Supra because it is above the spine. Supraspinatus muscle. This muscle, if we look at its tendon, here is the tendon. The tendon passes superior to the shoulder joint. So the tendon fuses with the capsule of the shoulder joint and supports the joint superiorly. And let us stand for this muscle also with the letter S, supraspinatus S, and subscapularis another S. Below the spine, inferior to the spine, there is another muscle called infraspinatus. Infra means below the spine, infraspinatus. Look at the tendon of this infraspinatus muscle. This is the tendon. Its tendon also fuses with the fibrous capsule. and supports the capsule. From which direction? Supports it posteriorly. The fourth end, the end letters stand for the muscle with the letter I. Okay, so S and I. The fourth muscle, which we can see from the posterior aspect, is a muscle called teres minor, attached also to the scapula, and it goes to be inserted into the humerus. Let us look at the tendon of the teres minor. Here is the tendon. It also fuses with the fibrous capsule posteriorly to support the joint posteriorly. And we put the letter T for the teres minor. So as you see here, there are four muscles. Initials, let us say it is sits, as if one is sitting. S-I-S-T, sit. Sits, S-I-T-S, sits. Okay. S for subscapularis, I for infraspinatus, T for teres minor, and S for supraspinatus. So these four muscles, the tendons, fuses with the fibrous capsule anteriorly, superiorly, posteriorly to support the shoulder joint. So the main stabilizing factor of the shoulder joint are these muscles, and these muscles are called muscles of the rotator cuff. Muscles of the rotator cuff. They support the shoulder anteriorly, superiorly, posteriorly, except we did not mention inferiorly, except inferiorly. They keep the head of the humerus in the glenoid cavity, so the joint is stable. So this is the main factor for the stability of the shoulder joint, the tendons of the rotator cuff, which are the sits muscle. The second factor for the stability of the shoulder joint is the coracoacromial arch. We said before, this arch is formed of the coracoid, the acromion, and in between a ligament, which is called the coracoacromial ligament. And this coracoacromial arch forms, as we said before, a secondary socket for the head of the humerus or for the shoulder joint, and it prevents the upward displacement of the head of the humerus. It prevents the upward displacement of the humeral head, so it causes its stability. The third factor for the stability is the labrum glenoidal. We said that the glenoid cavity is a shallow cavity, so as to be deepened, there is a rim of fibrocartilage, which is the labrum glenoidal, attached to the margins of the glenoid cavity to make it more deep, so that the head of the humerus fits more to the glenoid cavity. So this is the third cause of the third factor for the stability, the labrum glenoidal. Lastly, the long head of the triceps. Okay, it supports the joint inferiorly, but only when the arm is abducted. Abducted means when I put away the humerus away from the trunk. Just in this position only, it may support the joint inferiorly, but otherwise the shoulder joint is not supported inferiorly. So these are the factors which cause the stability of the shoulder. In this slide, we can see the picture of the shoulder joint from the back. This is the posterior view, and we can see a yellow structure which is related inferiorly to the shoulder joint. This yellow structure is a nerve called the axillary nerve. You will take it later on. So inferiorly, there is an axillary nerve that is related to the shoulder joint. We will see what is the clinical importance of this point. Next slide. Here is the head of the humerus articulating with the scapula to form the shoulder joint. What happens if this head is displaced from its place, from the glenoid cavity? It comes out from the glenoid cavity and is displaced from the glenoid cavity. A condition called dislocation of the shoulder joint is formed. So what is meant by dislocation of the shoulder joint? It is displacement of the head of the humerus from the glenoid cavity. Let us think the head of the humerus. Where is the direction of this dislocation or this displacement? Is it more frequent to happen anterior, posterior, inferior, superior? When this head is dislocated or displaced, where will it be dislocated? As we said that the rotator cuff muscles, these supports the joint anteriorly, superiorly, and posteriorly, right? And the coracoacromial arch, it prevents the upward displacement of the humerus, the head of the humerus. So the most position which dislocation might occur in is downward displacement or downward dislocation. So downward dislocation of the shoulder joint is the most frequent type of dislocation. And as we just said, that the axillary nerve is inferior, as you see, to the shoulder joint. So what will happen is injury to the axillary nerve might take place. So when downward dislocation occurs in the shoulder joint, the axillary nerve might be injured, okay, and cause injury of it. With later on we will see the clinical picture of this axillary nerve injury. The nerve supply of the shoulder joint, there are three nerves that supply this joint. A nerve called the suprascapular nerve, the axillary nerve, and the third one is called the lateral pectoral nerve. You will take them each separate in the part you will study later on. Suprascapular, axillary nerve, and lateral pectoral nerve. We come to the last point in the lecture, which is the movements of the shoulder joint. Before demonstrating the different movements of the shoulder joint, I would like to tell you a couple of points. What causes the bone to move? The skeletal muscles which are attached to the bones, when they contract, they shortens, and the insertion of this muscle moves towards the origin. This black arrow indicates the shortening of the muscle and the line of pull, the movement of the insertion toward the origin. So they contract and shortens, and the insertion moves, pulling on the bone which they are attached to. Okay, so the first movement we have is the flexion movement and then the extension movement. The flexion movement is moving the humerus forwards or anterior. Extension is moving the humerus posterior. If we look to the third picture of the muscles, we have the deltoid muscle, which is a muscle that surrounds the shoulder. It has fibers, anterior fibers, middle fibers, and posterior fibers. The anterior fibers passes in front of the shoulder joint. Okay, so when these fibers contract, they will pull and they are attached to the humerus. So when they shorten, they will pull on the humerus, causing flexion of the shoulder joint. Also, there is another muscle called pectoralis major muscle. This muscle also is inserted into the humerus, and the clavicular fibers passes in front of the shoulder joint. When these fibers contract, they will pull on the humerus and pull it forwards to cause flexion of the shoulder joint. Unlike the posterior fibers of the deltoid muscle, the posterior fibers of the deltoid muscle passes behind the joint, so when the fibers contract and shorten, they will pull the humerus backward. so they will cause extension of the shoulder joint. There is another muscle which is called the latissimus dorsi muscle. It is one of the muscles of the back. It extends from the back and it is inserted into the humerus. So when this muscle contracts also and the fibers shorten, it will pull the humerus backwards. So it will cause also extension of the shoulder joint. The next movements of the shoulder joint is abduction and adduction of the shoulder joint. What is meant by abduction? Abduction means movement of the humerus and the arm away from the trunk. Adduction, moving the humerus and the arm towards the trunk. We have heard about the supraspinatus muscle. Its tendon is inserted into the humerus. It moves above the shoulder joint. When this muscle contracts, so it will pull on the humerus and cause abduction of the humerus. Unlike the pectoralis major muscle, when the pectoralis major muscle, it is inserted into the humerus. When the muscle contracts and the insertion moves toward the origin, okay, so it will pull the humerus towards the trunk and causes adduction of the humerus of the shoulder joint. Another movement of the shoulder joint is medial rotation. What is meant by medial rotation? If you try to put your arms like in the picture behind your back, what happens to the humerus? The humerus will rotate inwards or rotates medially towards the midline of the body. So this is medial rotation of the humerus. If we want to get it back to its position, to return your arms again to its position, or to rotate the humerus outside or lateral away from the middle line, so this is lateral rotation. So we have medial rotation of the humerus. It's an inward rotation of the humerus towards the midline. Lateral rotation, it's an outward rotation of the humerus away from the midline laterally. Some of the muscles which makes medial rotation is the subscapularis muscle. The subscapularis, as you see, if it contracts, it will pull on the humerus and cause its inward rotation or medial rotation. In addition, also, it can pull the humerus to the side of the body or to the side of the trunk, so it can cause or make adduction as well. Infraspinatus muscle, it's a muscle in the back. It passes behind the shoulder joint, is attached to the humerus. If it contracts and pulls on the humerus, it will cause lateral rotation of the humerus. So the infraspinatus, it's a lateral rotator of the humerus. The last movement is called circumduction, and it is a combination of all movements together. We can make flexion, medial rotation, abduction, adduction, extension. It's a combination of all the movements. It is called circumduction. As you see, we have mentioned in this lecture the type of the shoulder joint and the fibrous capsule and the synovial membrane, the different ligaments of this joint, and the clinical note about the dislocation of the joint and to which side or to which direction does the dislocation occur. And finally, we demonstrate different movements of the shoulder joint. Thank you very much.